where we're going to put the rectus femoris. One of the four quads goes to the hip. Everybody thinks, all these big muscles in the front, hip to the tibia. Not true. Not true. Just one of them. And it goes right there, just below where the inguinal ligament. So we're going to come to that in just a moment. The anterior superior iliac spine over here where? Pubic, brainless, tubercle, I'm happy with any of those words, it's fine. The pubic bone to the anterior superior iliac spine. Now, this border coming down this way, this is this muscle on this side. Well, let's do this one because we just finished this one. This border on the lateral side here, you can see, is the sartorius. And where does it attach here? Shares the attachment with the inguinal ligament on the anterior superior iliac spine. It comes all the way down here and attaches on the medial proximal side of the tibia. And then the other border here is this muscle that comes from the pubic bone and travels over. It is the most superficial of the muscles named adductors, right? In order, if you went superficial to deep, you would go longus, brevis, magnus. Longus, brevis, magnus. That's the way we do it. So the superficial one here is the longest. That's the border of the triangle. So when you're finding these blood vessels, when you find the femoral artery, that's where it is. That's where it's located. In that gap between the sartorius, the longus, and the inguinal ligament. Now the floor of the triangle should not surprise you. The iliopsoas and the pectineus. The iliopsoas, the psoas major and the iliacus, and the pectineus, which goes, you remember, I know I just taught it to you, this one goes from the pubic bone over to the lesser trochanter to share the attachments of the iliopsoas muscle. Okay, so that's the floor of the triangle. Now, here's another shot of it to tell you that these blood vessels are in a sheath, which is different anatomically. I like to point this out because this is a clinical observation. You never hear about anyone who has a heart procedure having paralysis or motor deficit problems in their leg caused by the procedure. Now, no doubt, you're going to worry about sticking this femoral artery because there's a lot of pressure in there. And before you're done with me in this class, you're going to have a very good answer to the question. If all the pressure is in the artery and there's no pressure in the vein, nobody worries about you bleeding out by cutting a vein. If you cut an artery, that is a life-threatening cut. Why then, in accessing the femoral triangle to work in the coronary arteries, do they want to access the femoral artery instead of the femoral vein? So later in your life, something to look forward to. I will force you, this will be a test question on your circulation test, tracking the blood vessels from here up to the coronary arteries. So the first time you go into a surgical suite and the doctor that you're shadowing is stringing the stent through the femoral, and the surgeon looks at you, the undergrad, and says, can you tell me, look on the picture that we're looking at, can you tell me where we're going? You're going to go, as a matter of fact, I can tell you that. Yes? So everybody doesn't listen while I teach you the anatomy of how we're going into the heart from here. Now, the reason there's no trouble here, can you see it, is because the femoral canal here, the nerve is actually not in the sheath with the blood vessels. So you don't do damage to the nerve here, which is different than the way the blood vessels in your neck are. Now you've learned a little of this already. You already know that in your neck there is a common carotid artery coming up your neck that splits into internal and externals. We talked about the vascularization in the head. The carotid sinus is where that split is. Now the internal carotid off of that branch goes into your head through the carotid canal of the temporal bone. I should be ringing bells there, right? The problem with that blood vessel is that in the sheath with the internal jugular and the carotid is the vagus nerve. The 10th cranial nerve is in the sheath. Now, what division of the autonomic nervous system is the vagus a part of? Yeah, just keep coming back to it, right? It's parasympathetic. Okay? What does the vagus do to your heart? It does, but tell me more. When you think parasympathetic, the phenomenon you're thinking of is rest and digest. What does it do to the heart? It slows it down. And if you touch a nerve, you have stimulated it. So if you go into the carotid sheath to clean out a carotid artery, for example, you access the carotid blood vessel and you touch the vagus, what happens to your patient? Their heart stops beating. It's a very different phenomenon here in the leg where the nerve is not in the sheath. In your neck, the nerve is in the sheath, but not in your leg. So it's an important little tidbits here for the femoral triangle. And you've made a big enough deal about it. Let's do the quads. Here are the quadricep muscles. Vastus lateralis first. This is the most lateral muscle in the anterior compartment of the leg. It's attached to the greater trochanter and the linea aspera. Okay, where's the greater trochanter? Does vastus lateralis fit in our description of? Yeah, this is why I pointed this out. It's out there lateral, vastus lateralis. Does the linea aspera bother you? I don't think of the quadricep muscles as being posterior muscles, but in fact they are. The vastus lateralis has a linea aspera attachment. Now I have patella here, but let me explain what I mean by that. All four of these, the lateralis, the medialis, the rectus femoris, and the vastus intermedius, all four of them, called the quadricep muscles, attach the patella. Now we're going to learn the names of these tendons. The one on the medial side is called the medial patellar retinaculum, and the one on the lateral is the lateral patellar retinaculum, and that's fine. I get it. So I'm going to cut the knee open. I open up the knee and I look. There's a big tendon sheet there where all the quads are coming together to sit on the patella. But we also know that these four muscles have as their primary responsibility extension at the knee. They make your knee do this, extension at the knee. There's no way for those muscles to extend at the knee by attaching to the patella. That will not work. You've got to do something to get to the lower leg bones. And so they actually fuse into the patellar surface and into the ligament that then proceeds downward to the tibial tuberosity. The real attachment, y'all, the real attachment that matters for the quads is on the tibial tuberosity. That's why there's a knot on the front of that bone, because all four of these big muscles on the front of your leg have been pulling on it for so long. The tibial tuberosity. So when I say that, I'm not going to say it again. That's it. On the other three, the insertion's not even listed. They're all going to the same place. So here they are. The rectus femoris, the vastus medialis, and the vastus intermedius. Okay, so the rectus femoris, I mentioned this, goes to the anterior inferior iliac spine. That is very close to the anterior superior iliac spine, where I will find the inguinal ligament and the sartorius. So the rectus femoris is the only one of the quads that goes all the way to the hip. It goes all the way up to the anterior inferior iliac spine. Here's to help you remember it. On the front, the quads have but one of the four that goes to the hip. On the back, for the hamstrings, they have but one of the four that doesn't go to the hip. And that would be the short-headed bicep. So I'll point that out to you again. It's a good way to remember it. All four of these four in the front, only one goes all the way up. It goes to the anterior inferior iliac spine. This one attaches to the linea aspera and the intertrochanteric line. So I mentioned this a second ago. This line here between the lesser and greater trochanters, the intertrochanteric line, Can y'all read what that says right there?
Ilioifemoral ligament.
The iliofemoral ligament. You recognize that name? Okay, there would be two others associated. There would be one across here to the ischium and one across here to the pubis. So this is just one of the three that you guys named for me just a moment ago, showing you the iliofemoral here. There's the anterior inferior iliac spine. So what muscle attaches there? The rectus femoris. Right. Okay, these all get femoral innervation. And then the deep one, oh, okay, so I mentioned this one. Oh, this one's interesting actually because it doesn't even, the vastus medialis is actually, in terms of its attachment, more posterior than it is anterior in the thinking here. So I'm not going to ask you that, but you can see here it has its major attachment on the back, as does the vastus lateralis. Okay, the last one here is the deep one. This one is deep to the rectus femoris. It is attached to the anterior and lateral femur. The only reason I put lateral here is because, well, because it's lateral. And when you dig down deep here, you're not looking for this muscle on the medial side of the femur. It's actually a little bit lateral in your dissection. Okay, so that's the quads. Now, if we're going to do the hamstring muscles on the back of the leg, we have to do the sacral plexus. And you know, the lumbar is not as bad as brachial, and the sacral is about the same as the lumbar. In fact, there are textbooks that don't separate them, lumbar and sacral plexus. They just talk about a lumbosacral plexus. But I think it's easier to separate them out because I like to think about lumbar as being femoral and obturator. And I like to think about sciatic as being tibial and fibular, separating these two. I like to think about the lumbar as being front of the leg and sciatic as being back of the leg. Okay, so this one leaves the pelvis via the greater sciatic notch. Okay, anatomical experts. Where is the greater sciatic notch? Yeah, excellent. So that's why I brought this up. So we're taking the sciatic to the back of the leg. This is a posterior notch. So I threw this picture in here for today. It's not in the presentation you're looking at, but it says exactly what you just said. So there's the anterior spine, there's the posterior spine, here's the big sciatic notch here. This is actually a lateral view. There's the acetabulum. What would be the name of the ligament that would have its two fusion points here out of the fovea capitis? The round ligament, yeah, the ligamentum teres goes in there from the fovea capitis and the head of the femur right there. There's your obturator foramen. And so I just wanted you to see the greater sciatic notch. And since I brought the hip up, I wanted to show you this before we start down with the hamstring muscles. I didn't mention this earlier with the hip stuff. We were waiting until we got here. But I threw a picture in here today to show it to you. This is actually the easiest way to tell a male skeleton from a female skeleton, the hip. Can you see it?
Yeah.
Yeah, so the plastic ones in the lab, they don't try to make it male or female. It's some neutral gender. But I have a skeleton, a real one, in my office. And if I won't tell you, if one day you walk by, just come in and have a look. See if you can tell if it's a girl or a boy. And so how would you describe that?
Wider.
Rounder and wider than those.
More narrow.
Okay. Okay. Yeah, all those are true. The easiest way to say it would be the ilium of the female is flared. The ilium is flared. It's a good way to tell the female pelvis from the male. Now, the other interesting thing about the female pelvis is this idea of a pelvic brim. Whenever ladies are having children, they refer to this pelvic brim because it matters for childbirth. If the borders of the true pelvis, which I'm about to describe to you, are not large enough, then you have to have the baby cut out of the front. So there have been a lot of human females who have died in the history of humanity because of this. Because of a pelvic brim that was not large enough. So let me define it for you very briefly, and then we'll move on to the hamstrings, since we're moving around the hip here. This dotted line represents what we refer to as the pelvic brim, and you can see that it touches the first sacral bone, known as the sacral promontory, and then if it were a plate, a paper plate that was sitting on this, the edges of that plate would then touch portions of the ilium. It would touch a little bit on the ischium here, and it would touch here on the pubic bone. So it would touch the bony rim of the hip as it proceeds posterior to anterior. Y'all see that? That thing is sitting like this. The pubic symphysis is out here, anterior. This sacral promontory is in the back. And so the plate sits, you would sit the paper plate down on the skeleton like this. And the borders would be the sacral promontory around the ilium, touching a little piece of the ischium, and coming all the way forward to the pubic bone. Now, the reason that's important is because everything inferior to that is a bony border. So that is a bony margin. There's no wiggle room there. The only real wiggle room here is this piece of cartilage in the pubic bone, the pubic symphysis. And so when it's time, we just talked about this with Dr. Payne, when it's time for the baby to come, the placenta makes a hormone called relaxin. And the reason it got that name is because it softens the cartilage in the joints. It's not pleasant because it doesn't just focus on the pubic symphysis. It focuses on all of the cartilage and ligaments all over your body. So it's like you become,
Jelly.
huh? What's the word y'all use?
Jelly.
Jello, yeah. And it creates pain all over the place. It's like you're coming loose. And the reason for that is to create at least a little bit of margin for the child to pass through. Because the uterus sits right here, and the baby has to go this way, posterior to the pubic symphysis. That's where the baby has to go, through the bony pelvic brim. That area that the baby has to pass through is called the true pelvis. That's everything posterior and inferior to this brim. The false pelvis, or sometimes called the greater pelvis, is the area on the front of that. That's where the baby has been pushed out into during development. But when the baby comes out, got to go through a bony canal. Got to get small, got to get squeezed through the bony canal. Head's got to get squeezed too, right? Got to be some fontanelles to help squeeze through this bony canal. All right, now to the back of the leg. So we did this, review this. I put it up on the slides over and over again. Review we did femoral obturator. Now we're doing tibial and common fibular and the gluteals. And the first one we're going to do is down here, y'all. We're going to talk about the butt muscles first on the back of the hip here. So the superior and inferior gluteal. It's a little bit weird if I said before you knew anything, I said to you there's 3 gluteal muscles. Now, 2 of them you have to learn on your cat. The maximus and the medius, right? The minimus is not labeled, okay. It's a little one. But their locations on the cat are also, the attachments are not exactly the same as they are in humans, okay? But you learn the human attachments, right? Identify the muscle in the cat, learn the human attachment. Okay, so these are the gluteal muscles. If you learn the name, you would think gluteus maximus, that's the big one, the top one, the largest one. That's got to get superior gluteal. Not so. Inferior gluteal, this is the top one. And so this one gets the upper portions of the sacral plexus, and this one gets lower. So the superior gluteal then picks up the medius, the minimus, and the tensor. This is the muscle of the IT band coming right here. Tensor fascia latae. Okay, so here they are. Right, all that's repeat, right? Sacral. I got back pain. Where's the back pain? It's radiating down my legs. It's sciatic, right? It's L5. It's it's L5, it's S1, it's S2. The pains are normally out on the lateral and posterior aspects. These are sciatic phenomena. Okay, now, good, here they are. The maximus first has attachments to the ilium sacrum. We'll stop with this slide. I think we'll maybe get one more because I'll explain the attachment with the IT band here. So the ilium, the sacrum, and the coccyx. The gluteus maximus attaches to the ilium, the sacrum, and the coccyx. That's kind of like the magnus. That is a big muscle. It then attaches over to the gluteal tuberosity, a knot on the back of the femur, the gluteal tuberosity, and to the IT band, the iliotibial tract. This is what it looks like right here. The IT band is actually the tendinous extension of the tensor fasciae latae, which is a muscle that attaches to the iliac crest and the anterior superior iliac spine. This one you can see in your cat. It's a triangular muscle. This big, thick tendon is really hard to cut, is on the cat, really easy to find, this tensor. It's on the anterior superior iliac spine. You getting the list? The tensor is there. It's part of the IT band. The upper border of the femoral triangle, the inguinal ligament is there. The upper attachment of the lateral border of the femoral triangle, the sartorius is there. The anterior superior iliac spine, and on the crest here. And then the band, this one gets superior gluteal, which is interesting. That's the one that the medius and the minimus get, the superior gluteal. And then the tensor fascia has this tendon that comes all the way down here to attach. It doesn't say it here. It attaches actually on the tibia. So you can see it coming across here to attach to the lateral condyle of the tibia. Now, is the tibia the most lateral bone in your leg? The fibula is. So what does that tell you? If this guy is not attached on the head of the fibula, what does that tell you about where the fibula attaches on the tibia? We haven't made it this far yet, but you know this from the skeletons you learned, right? Is the fibula a weight-bearing bone?
No.
Does it have an articulation with the femur? It does not. Okay, so it does. It's not really the anatomy person is really not surprised by this. It is lateral on the tibia, but it's not on the fibula. So it's a very proximal attachment on the tibia. This is another one of those questions that I have. We develop these over time. There's a lot of questions about hormone things and nervous system stuff that I like to bring up. This is another one. This really says to the human race, you do not need to be running marathons. I would argue with anybody. This attachment, the IT band, says that. And a marathon runner will admit this to you. Very few of them have lived their lives without problems with this guy here, the rubbing of the IT band here. Now, a couple reasons I bring it up. I wanted to teach it to you, but the other reason I wanted to bring it up is because this is listed in your textbook as an attachment of the gluteus maximus, the IT band. All right, the other two are the gluteus medius and minimus, and that's where we'll stop. The medius then attaches to the ilium and the greater trochanter, and the maximus attaches to the ilium and the greater trochanter. So that attachment makes perfect sense for those two. That is superficial to deep, maximus, medius, minimus, which will be a problem in your cat because they are not superficial to deep in your cats. All right, when we pick up next time, we'll do a little review on the sacral plexus, and then we'll do the hamstrings and the knees and the muscles below the knee on Wednesday. We're getting close to being done. So all of you need to say something nice to Emma. Tell her that you're loving life, learning anatomy,
Elsie is great.
and that she should be a science major and not an education major.
Oh, yeah, don't go educate.
Yeah, no.